explain about the CCLADs and the CDPs. Go to the CDP, how will you travel? And also, this mother is with a child, and you want her to be in the village. This mother doesn't need to know that everyone knows she goes in that place people don't disclose, and sometimes they don't feel it well. Someone will travel a distance of 10,000, actually even 30,000 a day, just to come to the facility because they don't want others to know them. Then what else was there about? I think that's it. Okay. Right?
Yeah, so maybe just to summarize, actually, when we go to the field, we find this preference for facility-based DSD models than the community. Yeah, and then also, maybe just to add to your question, the stigma index. Because how is it now? In the interventions you mentioned, it didn't feature, and yet stigma seems to be coming down.
Okay, thank you very much, Doctor. During your presentation, it was like the burden is high in girls, and we forget that who are affecting these girls. So what plan do we have for mostly these men who are affecting? Because men have poor seeking behaviors, health seeking behaviors. So I don't know what the plans you have for these men. Thank you.
For you, men. Okay, thank you.
Thank you very much for the questions. The first one was on the social determinants. How can we help? You saw that in one of the slides, we are emphasizing a multi-sectoral collaboration, because in the Ministry of Health, it might be challenging for us to address some of these issues. But we know that here in Uganda, we have a whole ministry, the Ministry of Gender, Labour and Social Development, that is able to, that has the parish development models, that has the youth livelihood program. So the best we can do as Ministry of Health is to create those linkages. And over the years, we've seen a lot of increased collaboration in terms of what we do together, including the Ministry of Education, where most of these for those in boarding school. This through a multi-sectoral collaboration. We still have a lot to do, but one of the beginning steps for this year, building on what we've been doing, is the integrated community model, where we are now looking at all the community support. When you go to an area, you look at all the different community support persons, because previously we've been having the apps going to this home to visit an adolescent. While they are still there, the peer for the pregnant mother also comes in the same household. As those two are living, the ones from gender, they are called what? I'm forgetting the ones. The parasocial. The parasocial worker also arrives. While they are still there, the VHT also comes with malaria kits and mosquito nets. And they are all going to one household. So now, through the integrated community-based facility model, we are saying that let the stakeholders working in that region map out all those parasocial workers, the VHTs, the Qs, the YAPs, the community health workers, all the different names, the meta mothers. Let us allocate them to particular homes and clients, so that we strengthen their capacity to deliver services across all these broad areas, so that you avoid that repetition, because the households also get overwhelmed. So through that, we are hoping that as we begin to work together strongly, we'll be able to begin addressing some of these social determinants. The second was on the supply chain interruptions. We are now going to 3-month cycle from 2-month cycles, and already we've been having challenges with the 2-month cycles. What I can say is that from our colleagues in logistics, there's been a lot of initiatives to try and improve the forecasting and reporting systems, and that has come to an end, to a conclusion, and we hope that now the ordering and the reporting through the electronic system is now okay. There were changes that were being made, especially to address some of the things that were missing, the new commodities that were added recently, breaking down to reflect the different age groups that we are looking at. So there's been those revisions that have been happening. We are also, the logistics team, and we work together with them, does forecasting every month. Every 6 months, we review what we have with an attempt to make sure that we are doing the correct forecasting, we look at the numbers. But what is important for us to also understand is that the lead time for these drugs to come is 6 months. The team starts on this process early, but sometimes the challenges are beyond the country program. I'll give you a very good example. When lopinavir was first introduced, I think the manufacturers did not anticipate that there would be a rapid uptake of the drug. So we went through a period where you could not get lopinavir anywhere on the globe. So there are many factors that come in, the speed of manufacturing, and when it comes to the children, the numbers are reducing. The adolescents are edging up into the adults. So sometimes it requires that country pull orders for them to be able to manufacture. Because the smaller you manufacture, the smaller the numbers, the higher the cost. So there are many dynamics in there, but which we are trying to work around, and the global community is also trying to work around to make sure that some of these challenges are resolved. I also forgot to mention during my presentation that very soon we are going to be introducing a fixed dose combination of pediatric abacavir, lamivudine, and dolutegravir. And we hope that this will also support in improving adherence. And we'll be training, because the fixed dose combination includes pediatric DTG 5 milligrams, not 10. So it's going to be very important for us to understand that, and to know that you cannot begin dividing the ABC3TC and DTG and saying I'll divide in half to give, because the drug formulations and strengths are different. So guidelines for CD4 and TB-LAM for clients who have AHD, there is a reason why the guidance says first do a CD4, and then the CD4 guides you. So if you do it the other way around, you're certainly going to run into those issues, because the TB-LAM test has, according to studies, it works best when the person has, exactly. So if you're doing in a person who is above the cutoff, you're causing problems for yourself, and you're also causing wastage, because you're doing what you should not be doing. So we are supposed to follow the guidelines, because if you do that, you're going to end up treating when you should not be treating, because the sensitivity of the TB-LAM when someone is not immunosuppressed is different from that when someone is immunosuppressed. So please stick to the guidelines. It will help you to manage your patients better, It will also help you to avoid wastage. So the presentation is going to be provided. It has already been shared. The interventions that are resource intensive, yes, we know that most of our program is heavily donor funded. That's why in our next steps you saw the section that was saying we want to integrate into the primary healthcare services. That is like our really catch way of doing it, because in terms of the resources, we're still heavily relying on donors to procure our drugs. The Ministry of Health has over the years increased the contribution to the procurement of the drugs. I think from the time I joined the Ministry of Health, it has more than doubled. So we are on a good path, and we hope that with time we'll get to that point. We now have ARVs manufactured within the country. So we are making progress. We are not yet there, but we are on a good road. Yes, the DSD, we understand the challenges. There's also the perceived better quality of care when people come to the facilities. So the questions we should be asking ourselves, when you look at our new DSD schema, it has, I am personally doing a study with a few people to try and establish which are the preferred models. Because we have over 10 models that are being tested. And we have a limited resources. How should we instead go back to the people and find out from client reaction? And here in the conference rooms like this with the AC, over nice breakfast, and we think this will work for them, and it's actually not working. So we need to go back to the drawing board and establish what works for them. What do they want? And maybe that's what we should be implementing. Interventions for men. We have, as Ministry of Health, come up with the men involvement, men engagement. We've called it different names, but you're still not coming. So maybe you need to tell us what will work for you. But there's a whole Ministry of Health document, the male engagement strategy that we have, and we are doing our best to implement. But we need more male peers. We probably need focus group discussions, human-centered designs to really understand how we can reach the men. The men should be telling us, because as Ministry of Health, we've developed the document, we've involved stakeholders, but the male engagement is still low. It has slightly improved, but it is still suboptimal. So with those few remarks, I will end there, and thank you so much again for inviting the Ministry of Health to participate at this meeting.
All right, so thank you very much, Dr. Elena. I think for the other subsequent questions, maybe as we are interacting, taking tea, you can approach her and then you ask another question. Because I know there are questions, you're learning questions. Okay? So yeah, it's tea time. So if there are any other questions, please approach her as you take your coffee. Thank you. I hand over now. Thank you.
Wow. Thank you very much, Dr. Maki, for giving me this microphone. But of course, not forgetting our own. And let me have somebody lead us in appreciating Dr. Elena. The presentation, who is leading us in appreciating? Pastor. Pastor, the vote is on you. So what are we going to do? Just guide us.
Sana. Asante sana.
Doctor, thank you very, very much. I wish we had you for all the 3 days. Did you enjoy? I was hearing things here and very, very important. we did get somebody in charge of welfare. We shall talk about it and we get that person. But key things, Doctor, I heard very well that us being led by Marian, the implementing partners, must be guided by where need is. I heard that very well. Then optimal treatment is working, and I hope we are all implementing at our facilities. But she has also said that the gravia is not, I don't know how to mention very well like her, but it's not the magic bullet. Did you hear? It's not the magic bullet. But the magic bullet, to be complete, we have to bring it in place. The hearance bit, the psychosocial support. So we take care of the social determinants. We address the structural barriers. She mentioned that we have a leaking tap. Do you remember that leaking tap? Which one is it? Retention somewhere. And then I also had a highlight that when we are looking at the retention and we have the loss to follow, that we do follow up that very day. We don't wait after 3 months like we used to do that very day. And then I was very happy again to hear that ARVs are being manufactured here. Next year she will tell us even our very government is funding everything. Why don't we give her another? Hey, you want the caravan site? Okay. Caravana, señorita. No wonder she can dance. She just fears. Isaac, who is welfare praying for us? Who is praying for us? To go for break. Faster. Pray for break too. You just walk out right here.
Okay. Lord, we thank you for the food that you have provided to us. We request you, Lord, to have that food provide us with energy. You can do the work as we expect. We thank you for Jesus Christ. Amen.
Amen.
And if you believe with me, rise on the feet and let's sing together. Yo, 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 yo.
Well, a huge welcome to this year's PATA Summit. My name is Patrick Oyaro. I work for City Health, based in Kenya, and also as the Chief of Party for USAID's Tawisha Pwani. And I'll be chairing this session. And on behalf of the PATA Board of Directors, I extend a warm welcome to everyone, those joining online and hundreds of participants connecting through the 24 countries in-person satellites. This year's summit is aligned to the new Global Alliance to End AIDS in Children by 2030. And today's theme at the summit is focused on localizing and building momentum around the new Global Alliance to End AIDS in Children by 2030. So I welcome all of you and know that this year's summit will build action to do it right, do it together, and do it now. Before we start the session formally, I would like to introduce two satellites. I want to give two satellites an opportunity to share their summit spirit and energy with us. So we are quickly going to give live to Team Cameroon. Team Cameroon, where are you? So is that Team Cameroon ready?
We've got Uganda and Cameroon. So Cameroon, maybe let's hear both of you.
Great, thank you. Thank you very much. We've heard from Team Cameroon and Team Uganda ushering us to the beginning of this summit. Great, welcome to all the speakers and presenters for this first prime session. You'll have seen them. We've already seen the presenters in the flyers that we've heard, and I will take this opportunity just to introduce them as they do their presentations during the session. So first off, we have Luan, Director of PATA, who will tell us a little about the summit, and after that, we'll go straight into the video. And then at some point after that, we're going to follow through with a presentation from Dr. Shafiq Esaji. I'll go ahead and usher in Luan.
Morning, good afternoon to everyone. Very warm welcome to PATA 2022 Summit. It's wonderful to be here with you. Many of you are already familiar with the PATA Summit and the objectives of the summit. I'm going to quickly run through a few of them again. As you know, this year's summit is really about building momentum and introducing the new global alliance to end AIDS in children.
Agenda of reaching out to children by getting to the community itself. AIDS Funds is part of the Breakthrough Partnership, which has 4 partners, AIDS Fund, PATA, EGPAF, and UNICEF. And this is a program that will be extending to another 2 countries in the coming year. And for every country, we have one of us offering the coordination role. And that is why Margaret introduced me as the coordinator of the Breakthrough Partnership. But on behalf of AIDS Funds, I help to bring together the 4 partners. I'm here to talk briefly about the role of health practitioners, community partners, and peer support in driving the agenda that we are looking at. And Dr. Edna has done a lot in making my work easy, explaining the focus of us as a country, but most importantly, on supporting all of us as we do the work that helps us to achieve the last mile, getting to the last child, and we've given ourselves the ambitious target of 2030. I'm really happy to note that we actually are getting there. Uganda as a country, we think we are getting there, especially in the area of optimizing treatment for our children and our adolescents. However, from Elena's presentation, we clearly notice that we are still not doing very well in terms of identifying all the children. And then, even the identified ones, we are not doing very well in terms of having them virally suppressed. So while we are doing very great work in enrolling whoever we find, and I really want to applaud the health workers in this room, for all the children that have been identified. When I talk about children as a planned mother I talk about children and adolescents. So I keep using children because to me, whether I look at a 19-year-old or a 2-year-old, to me they're children. So you'll bear with me when I talk about children and don't think that I've forgotten the adolescents. For me, they go in the same package. Last night I was listening to MC Katz and he kept on calling them kids. Then I said, no, this is going too far. Even the adolescents to Katz are kids. So I call all of them children. So while we are doing a very good job of making sure that we enroll in care all the children, but we have missed our point if all that we enroll are not very pressing. So we can't aid AIDS if the ones enrolled are not very suppressing, because that means that we still have those that can transmit HIV. So our job now is to identify up to the very last child. Ministry of Health has agreed with what we've talked about over the years, that children are born and raised in communities. So there is nowhere else we are going to find these children but in the community. The more we engage with the community, the more we will find these children. But even when children are born and raised in communities, we have the custodians of the services that they need. And these are the health facility workers. Over the years, we've had them sit in their offices, wait for us, and the children never came. They even made effort sometimes to move with us to the community to look for the children. But you see, that becomes a lot of work. And in most cases, we will not reach every child that we are looking for if the same person we expect to sit in the health facility is the one that is going to work the community. And this is where the community health worker comes in. They come under very many names. We have the VHTs, we have the parasocials, we have the linkage facilitators. Call them whatever you want to call them. But this lay health worker, the lay health worker at community level becomes important. But their importance is related to how much they are working with the health facility workers. Dr. put it very well, that you can have a beautiful program, but if this program is not very well coordinated, if this program is not very well managed, then you lose the gains. So, while we know that the community health workers are doing a good job, the health facility workers are doing a good job, if we don't bring these two together, then we'll still miss out on what we are looking for. So, who are these community health workers that I'm talking about? I want to drop the names that we use to describe them, and I put it in a layman's language for us to understand. When we talk about children born and raised in communities, these children can be found in different places. We can find the children at home, we can find the children at school, we can find the children at church, we can find the children in their play area, we can find children at the well, we can find children at the funeral. You know, there are different places where these children are found. And all these areas where the children are, there must be an adult that is appearing in this same space. And it is this adult or this person of influence in this space that we should look out for to help us to be a community health worker. If children are in school, they are there from 8 to 5, in some schools to 7. It means that the longest time of their weekday is at school. So if the teacher doesn't know how to deal with this child in the different situations that the child is in, then we are losing it. Because the mother or the father, in this case, only sees the child as they are waking up, and they see them as they go to sleep. So they will never have time to talk to them. The ones that are lucky will talk to their children as they drive them to school. But majority whose children walk to school, they will never have that opportunity. So empower the teacher to be able to address the challenges that we're talking about. Uganda is one of those countries that prides in being religious. Our children go to church. Our children attend children's church. Our children interact with those other teachers at church. But what are we doing with those important people at church who influence the lives of our children that much? So all this that I'm saying is we need to, as we think about addressing the social barriers for these children, we need to look at all those areas where the children can be found. So as we think about going into the community, as we think about working with the community, we should know who is this community gatekeeper. I don't want to use the traditional languages that you're using about the community gatekeeper. In this case, I'm talking about any of those stakeholders. In other words, who hold the stake. You can see my interpretation. Stakeholders, the people who hold the stake in the lives of these children. If we don't have them, then we'll miss out on what we need to address with the children. I've already emphasized the importance of collaboration. So the next one is, so having thought about this, what do we think is going to be the game changer? We've known that we need to work with the health workers because they're the ones that are going to give us the services. We need to work with the communities because we are either taking the services to the community or we are using the community to link to the health facilities. But what is it that we are looking for? The guidance from the ministry is we've already spent more than enough time on medical interventions. And we're doing well. The drugs are there in the right doses, they come at the right time, and the people who are supposed to give them are there. But where is the problem? The problem is where the children come from. And this is what we need to address now. So what are those barriers at household level, at community level, that are making it difficult for us to serve the children in terms of identifying them and also in terms of retaining them? So if we are going to work with the people that live with these children in the communities where they are, to look for them, then we already have the guidance. We already know where these children are. It was clearly displayed to us. We know the districts where these children are. So what we need is to focus on those communities and try to see why, even when people are willing to bring these children to be tested, why are they not being retained in care? Is it because they don't have the right food? So if the problem is food, are we going to start loading bags of porridge and taking them to those villages? No way. Yes, we can do it for a start. But for how long? You know, we keep saying, you know, when Tasso was here, we had cooking oil. When Tasso was here, we had porridge. But you can imagine, the person, Dr. Watiti has just told us the first time he discovered that he had HIV. Can you imagine if Tasso was still taking porridge to Dr. Watiti's home? From then, if the porridge was still being taken to Dr. Watiti's home, then maybe we wouldn't have had this window that Elena is telling us that, you know, back then, 90% of the drugs were cured, but now we are bringing it down to those very good percentages. If we had continued taking food to people's homes, then wouldn't be getting to the priority. So how can we think about sustainability of nutrition in people's homes? I'll quickly run through an experience that we found in one of our families in Soroti. We entered this household in 2017 on the Breakthrough Partnership. And unlike what we are used to finding malnourished, we find a malnourished mother. So we say that this is one of those households that we are going to focus on. In joining the savings group, this woman is going to be there. If there is any other economic empowerment, this woman of eating. I was in class. Not only did I find a good-looking woman with very children, 5 of them, family had food to eat and surplus to sell. So if we come with this one, then we can 45 million Ugandans. It's a matter of giving them the information. Who is going to give the information? Isaac, Ezekiel, Emma, and the rest of us who work with the communities. What they need is the information and why they think this is important. So while we are still on information, the challenge in some homes, yes, might be food, but the biggest challenge is these caregivers who don't know the importance. When they say give this tablet at the same time every day, they'll be like, it is still Monday. If it's a Monday tablet, whether I gave it in the morning or I gave it in the afternoon or I give it in the evening, it is still Monday. When we are giving these drugs, there is a lot of explanation that is given to the caregiver. But how much do they pick? We need to not only give this drug, but we have to make sure that the person taking the drug understands why and how they should take it. So as we do all those other things of looking for children, having them enrolled and thinking about having them retained care, making them literate about this treatment is very, very crucial. So one of the things that have to remain in all the programs at community level is treatment literacy, because we want everyone that is taking care of this child to know when, how, and what to give this child. In the interest of time, I'll give the last comment on community health workers. We are giving attention to community health workers. And they're doing a job. They are getting to these homes. They are doing a good job. But just like I questioned the sustainability of food, I also want us to think out the sustainability of taking Ezekiel to go to Isaac's home every morning or every evening to make sure that Isaac's son took his medication. The effort we are putting in community health workers should be extended to the caregivers. At the end of the day, for the next 70 years, this child that we have now is going to be in their family setting. So we should try as much as we possibly can to make sure that whatever we are doing with this child, the caregiver knows. And with time, everybody in the household that is trusted by this child, that their caregiver knows what they are doing with this child. So that when we get out, we know that we have left a program in the household. We've left it with people who understand how they are supposed to take care of this child and why they should be taking care of this child. My call to action: we cannot keep expecting good service from health practitioners. They are not motivated, they are not appreciated, want them to do. So let us give everything that is required of these health practitioners, whether health facility or at level, what we expect of them. We cannot do what bylaws, so what the facility says should be the same as what the health worker at the community says, should be the same as what the caregiver says, and should be what the child understands. We need to bring all this in the same program. And finally, there is no point why a mother should go for her check at the health facility and tomorrow test the child for immunization. The next day, she goes to pick her drugs, and the following day, she goes to pick the drugs for the child. We need to integrate as much as we possibly can so that at least we reduce this movement. I remember one time when at a conference and this young girl, and she said, HIV is going to become a job for me. I can't spend all my awake hours thinking about talking to this health worker, going to this facility, going to do this. I have many other things to do in addition to getting treatment. So the same thing goes for these mothers and for the children. We are not going to expect the mother to make all these movements to and from the health facility or the community dispensing a point or whatever, as if there is nothing else to do. If it's health, it's health. Whether it's my diabetes, or it's my HIV, or it's my pregnancy, they can be handled in the same fashion. But this can only be done if we are able to prepare the people who offer the services to do them in that way. All said and done, I think we are committed to ending AIDS by 2030, and this can only be done when we find children.
And if you believe with me, rise on the feet and let's sing together. Yo, 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 yo.
You eat first and you come and conclude.